Hello, and welcome to our presentation titled Granulomatosis with Polyangiitis, presenting with bilateral apical cavitating lung masses. My name is Adriana Morales, and today I'll be discussing an interesting and atypical case of GPA that presented with bilateral apical cavitating lung masses. Granulomatosis with polyangiitis is a type of small to medium-sized vessel vasculitis, primarily targeting the respiratory tract and kidneys. It's a rare disease with an incidence of about 3 cases per million people each year. Its pathogenesis involves anti-neutrophil cytoplasmic antibodies, or ANCA for short, particularly the C-ANCA subtype, which targets proteinase 3. Our case involves a 57-year-old female who presented with generalized weakness, myalgias, and respiratory distress. Initial lab tests showed leukocytosis and signs of sepsis alongside hypoxia. A CT of her chest revealed bilateral lung masses with central cavitation, raising suspicions for necrotizing pneumonia or malignancy. However, lung biopsy results pointed towards necrotizing granulomatous inflammation rather than an infectious or malignant cause. This finding, alongside positive C-ANCA and PR3 antibodies, confirmed the diagnosis of granulomatosis with polyangiitis. From this case, we derive several key clinical pearls. Recognizing GPA early, especially through symptoms like sinusitis and hemoptysis, is crucial for preventing organ damage. C-ANCA testing remains a vital diagnostic tool, which should be complemented by clinical and biopsy findings for a conclusive diagnosis. Always consider the possibility of GPA affecting multiple systems, particularly the respiratory tract, kidneys, and skin. Early initiation of immunosuppressive therapy using agents like corticosteroids and rituximab is essential for controlling disease activity and preventing relapses. This case is particularly intriguing due to its unusual presentation with bilateral apical pulmonary masses, which diverges from the more common small nodular type typically seen in GPA. This underscores the importance of considering GPA even in atypical radiological presentation. The pivotal role of C-ANCA and PR3 antibodies in the diagnosis cannot be overstated, as their presence helped us exclude other granulomatous differentials, such as sarcoidosis or necrotizing pneumonia. The histopathological findings of necrotizing granulomatous inflammation further solidified our diagnosis. Ultimately, our patient was successfully treated with high-dose corticosteroids, rituximab, and intravenous immunoglobulin, leading to a favorable outcome. This case highlights the importance of considering granulomatosis with polyangiitis in the differential diagnosis of atypical pulmonary presentation and reinforces the critical role of both ANCA testing and histopathology in reaching a definitive diagnosis. Thank you for your attention.